Okay, good evening. It's Wednesday, April 22nd. This is a regularly scheduled meeting of the Programs and Services Committee. Meeting is being audio and video recorded. In the room, we have myself, Julie Maliki, Vice Chair from Ward 3, and John Oliver from Ward 1, and Stephen Farrell from Ward 8. Online, do we have committee members? Is that
This may be Councillor Nick.
okay?
Yes, this is
Okay, we have Councillor David Mickley from Ward 2, member of the committee online. And we'll see if anybody else pops in. And okay, I don't see any of the potential guests yet for the second item. But for the first item, passing agenda. Okay. We have, I don't know whether to say commissioner or acting commissioner of Parks and Recreation, Mark Welch, and definitely always tree warden. We've also just been joined by Councilor Brittany Charm, member of the committee from Ward 5, and let's see who else. And we also have Jennifer Wilson from the law department. Okay. And okay, so the first item on the agenda is number 2626, requesting discussion and possible amendments on the application process for the tree permit applications. And as you may recall, at our previous meeting on this topic in January, we discussed two facets to this, authorizing the use of a standardized form for abutter neighbor notification, and also whether to expand the notification, extending it to all permits. So we had a basically unanimity on the use of a form and a split decision on the straw vote on whether to extend notification. So the first thing I wanted to do here was split this docket item into parens A for the use of a standard form and parens B for extending notification, so that we can do a clean vote on the language, which Ms. Wilson has prepared for us on the form part of it. So do I have a motion to split the?
Yeah, so moved.
Okay. All in favor? Aye.
Aye.
Okay, thank you. And do you want to put the draft language up on the screen there?
Yep.
Okay, so this language, I think, encompasses all the elements that we wanted to see included on the notification form, and it's produced by Ms. Wilson, and Mark Welch has already signed off on it. So are there any questions on this?
I'm going to plead guilt on this one, so the opposite of the fifth. I just need a minute to read this.
Sure.
Sorry.
Okay.
And perhaps, okay, question.
Sure.
I seem to recall that one of the things that we talked about, and I'll be honest, I don't remember exactly where we landed, was the notion of, did we want to include, and maybe this will go in the actual form or the letter itself,
Right.
that there was, not that we were going to say, hey, there's really nothing you can do about this, stop it, but to be aware of it.
Right.
But wasn't there language that we discussed that we wanted to include somewhere in that process? I do remember that coming up.
Well, the elements here would refer them to the city website for an explanation of what's in the tree ordinance and how to find the actual permit application itself in the documents. And each permit is going to be different,
Sure.
and it's not really final, so it's final. So it's more informing people to keep an eye on it as best they can.
Was your question?
Yeah.
Would your question be answered by number one? We'll wait to see what the explanation of why the notice is being.
Yes and no.
Okay.
It could be. I'm just trying to, because I remember us having the conversation. I remember the topic coming up.
Yeah.
I do remember us saying, well, should there be language in here saying what their, what next steps for an abutter could be, might be, should be. But I don't remember
Yeah,
what we
that can be on the form. It's basically to, be aware, you want to make sure your trees are protected as best they can be.
Right.
And
Okay.
this is how you find the information that the developer's arborist has prepared for a tree protection plan.
Okay.
Are you asking that, did we discuss putting in there something about why they're being told? Or what, or what
It
they
was
can
more
do?
or less, and I believe it might have been Counselor Charm who brought this up. Like, are we recommending abutters to go talk to the person that, the property owner who's having the work done?
Or we just,
Or are we literally saying, just be aware? And I remember the conversation, I don't remember where we landed.
Yeah, well, I think where we landed was that, we're not guaranteeing them rights, but we're making them aware that there is a responsibility on the part of the developer
To make people aware.
to have a tree
To know
protection
about it.
plan.
Okay.
does the commissioner recall that?
Does anyone have
He's
any
right.
questions for Mark Welch while he's here?
Commissioner, you want to ask him, or
Just one-
Commissioner, do you have any recollection of that conversation? Since you are, or your tree warden will be writing it?
So yeah, it'll be me. They'll be writing it. I recall. I don't recall the specifics of that. I think we can handle that. The good news is I think we can handle that within the letter, because this is.
Good.
This is gonna. Sorry about that. This is gonna be a form letter that they're going to use and fill in the details into the form itself. We could easily include. I'm open to suggestions and sending me suggestions on what that language could say. First thing that comes to mind is a simple statement, something to the effect of, if you have questions or concerns about the work I'm doing, here's my contact information, and we can require that be in the letter as well, which we probably would no matter what. Reach out to feel free to reach out to discuss, the project or something like that. We could put that in the letter to direct people that way.
Councilor Charm.
Yes, thanks. One is very basic context setting. As I was joining Councilor Maliki, I think I heard you say that we were splitting the docket item. So this would be revising the abutter notification, but this is not necessarily, voting on whether this should be going to all of the tree permit applications. Is that correct? I just want to make sure before we get into that.
That's the purpose of the split, so that we can just vote on this.
Yes. Okay, great. So we'll be handling that discussion separately. Okay, great. And then, yes, I think on the point about, why is this being sent? I think I'm comfortable here with, this language of like, the notice is being sent because, I am applying for a tree permit, to remove a tree or multiple trees, and I have a responsibility to be protecting other trees on abutters' properties as part of that. If you have, questions about the tree permit, including, which trees and where they fall on my property. I mean, that would be as a neighbor, that would be, and I know that we're not talking about residential, but like, I feel like that's one of the sort of the immediate questions would be like, well, which tree is this? And so I don't know whether we can actually share that in the abutter letter, or if the people are going to have to go hunt for it. But I feel like that would be sort of the immediate question of like, okay, well, is it, you know, the big, huge historic oak that I love so much, or is it, you know, that's like right on my property line, or is it one that's like way in their backyard and it doesn't affect me as much? So I think I'm working my way over to a question, which is, can we include in the abutter notice letter, you know, a little bit more detail about which trees are affected on the property, or, you know, do we need to be directing them to go hunt for it by looking up the tree permit?
That's the purpose of item number 4 there, how to obtain more information about the tree permit for which the application is being filed. Because, you know, it could be one big tree somewhere, it could be dozens of trees. Every permit is going to be different. And I think we'll count on Mark to make it as simple as possible, how to get to NewGov and find the permit information.
Is it possible to have like a one line, you know, description to say like, generally the trees that are being removed are blah blah blah, and then the, you know, the neighbor can put in a one liner, and then like for more information, like to see the specific tree permit. I feel like most, you know, I feel like that would be helpful to people to know, so they, you know, like they know whether they really need to be spending the time to go into the, you know, website and try to dig up the tree permit. Like, can we include one line about that?
I think the letter could. I think we have direct them to a letter will could direct them to where to find detailed information. But I don't see why we couldn't within the letter say it is our intent to remove X amount of trees on the property, or our intent to not remove trees on the property. I'd have to think a little bit about how to make that as easy for the applicant as possible in the process, but I think that's something that can be handled within the drafting of the letter.
Councillor Oliver.
And Councillor Charm, like, I think part of what I'm reading in this is the letter notice letter will include, because it says explanation why it's being sent, how to obtain more information. By that, I'm assuming we're going to say, and by the way, you can find the tree permit here, and within the tree permit application, the tree plan is a part of that documentation. So even though it might not be in the letter, it is the link to find it will be in the letter. Like the full tree plan is what I'm reading here. Because according to this, section 2183A2 or A1B, the tree plan is included.
And also, I
don't know if that's enough for, you know, close enough to what you're asking for, because I think it's in here.
And I think it's important to remember that what an applicant comes in with initially can change over the course of a project, and we don't want the recipient of the letter to sort of count on the blurb or the shorthand explanation of what they intend to do. Don't want them to count on that as being staying the same over time. So it's best to refer them to the actual tree permit in NewGov, where they can, if they want, keep up with any changes.
Got it. Okay. So in some ways, thank you, Councillor Malachy. In some ways, that's it's intentionally vague in the letter, because the details of which trees may be removed or what the tree plan is, that those details may change between the abutter notification letter going out and the actual tree removal happening.
Yes.
Okay. And my understanding is that this may not necessarily be sent electronically to people. In fact, it, you know, probably maybe printed and put in people's mailboxes or in some way. So if we can just make sure that we have clear, ways to reach it that isn't just copy pasting a link, right? But like actual instructions so that people can be able to get themselves there and find it, because as we all know, insert, difficulties. So with the website, actual telling them where to go would be great.
So if there are no questions, we have a motion to. Oh, Mark, yes.
Well, I was basically just, I was going to say this similar thing, thinking it through. When we issue, or when someone sends this letter to the abutters, they're doing so before the tree permit has been issued, because it's a requirement of the permit application to provide proof that you've sent this letter. So they may have a plan that they can send people to review. But once that application comes to us, we might find a problem with that plan and tell them they need to create a new one or correct something, or find some other issue that needs to be corrected throughout there, even before we've issued the tree permit. So the plan, although most of the time is pretty accurate and fine, but there are definitely times where we're asking for things to be changed between the time that they apply for the permit and when it's actually even issued.
So they will have completed the tree plan, but they will not have yet received the permit. That's the point at which this is happening.
Correct. Yeah. One of the things that the notification, whether it's what we currently have now or this new updated process, is one of the requirements to get a tree permit. If you haven't provided documentation that you've notified the neighbors and what you've sent them, we won't issue the tree permit.
Okay. Yeah. I just want to make sure there is something there for people to go in and figure out, like, okay, what tree is it? Right. That is coming down, or which trees. So I take it that's in the tree plan. Thanks.
Yes. Yep.
Ms. Wilson.
Hi, I apologize for not being on camera. The computer I'm on doesn't have a working camera at the moment, but I just had one suggested edit to the language that we had drafted. If you want to scroll up back to the definition section, after hearing you and Mark talk about a little bit more specific about the letter, I just wanted to suggest including the language in a letter in a form provided by the tree warden, which includes at a minimum the following. That way, if there's additional things that Mark wants to put in, there's no chance that this will be interpreted to limit what he can have in his letter.
I think that's so that Miles, can you do that in the
Make that edit, you mean?
what we're looking at?
Sorry.
Can you make the edit and what we're looking at? Or is that?
That's like a PDF.
Yeah, this is I mean, I could go in and edit the PDF, but I don't know if you'd like.
All right, well, so we would be inserting that where include, which includes at a minimum, so up in the first line there, which includes at a minimum the following.
Yes.
Okay. All right, that makes sense. Okay, so do we need to vote on that change?
I think it's reasonable to vote the item as amended.
As amended. Okay. So do we have a motion to approve the item as amended?
So moved.
Okay, thank you. All those in favor?
Aye.
Aye.
Okay. All right.
So that effectively then becomes 26A, correct?
That would be for the docket item number, yeah.
Right. That's what I'm talking.
And I guess, do we, I guess, could I have a motion to hold 26B?
Do you want to explain why you want to hold it?
Just so that, I think that's a longer discussion if we wanted to do anything more on that, and we are missing, I guess, at least 3 people.
Right, we're done. Yeah, in other words, we've got half of the committee here.
Yeah.
So we'll hold it.
Okay. All right. Was that a motion to hold?
I'm comfortable holding the part B of the conversation.
Okay.
Yeah.
Is that it?
All those
Well,
in
do you
favor?
want to, we should ask though, is there anybody here on the committee who wanted to discuss part B? Okay,
Okay.
now you're good.
All right. All those in favor of holding 2626B? Aye.
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 All right. So moving on to, and can you text Kelsey? Great. Okay. So moving on to our second item, number 10926, requesting a resolution to endorse bills supporting access to primary care. And let me see who's on here. Okay, so I just let Councillor Leary, who is the lead docketer on this, know that we're starting on this item. And I see Marie Greenberg, who is another co-docketer, and as is David Nickley. So we've been joined by that's Samantha O'Reilly from Cindy Cream's office
Doesn't look
for
like
the
her.
Senate side. It's Cindy herself.
Doesn't that look like the senator?
Yeah, and
Yes.
And I know Greg Schwartz, who is lead docketer on one of the primary care bills, was going to try to join us on Zoom.
With John Long.
He's out of state. We've also got John Lawn, state representative, part of Newton, and let's see. Now I was expecting great. Is Dr. Altman here? Or
He's
is
apparently not here yet.
Oh, okay.
Unless he's Zoom user and we can't tell.
No, he's not Zoom, he's coming in person.
Oh, okay.
Okay.
Well then, he's probably not Zoom user.
Okay, well, in that case, I'll do what I was going to do initially, and Councilor Leary wants to sort of introduce the item and give us some background. And any of the other co-doctors who would like to comment as well.
You guys have everyone has the resolution?
Yeah.
Okay. And I think Dr. Altman is, he's on his way.
And Councilor Farrell is co-doctor, so we actually have most of co-doctors.
Yes. Okay. So, you know, like one of the things that I have been very concerned about is the high cost of healthcare. And, you know, we're fortunate that we have a very high level of people that are insured, but many of them, like around 40%, have difficulty affording insurance. So the other issue is that we're seeing fewer and fewer people are having trouble finding a primary care doctor. There's a shortage of them. Many of them are retiring. And so the goal of this is to really encourage more young doctors to go into primary care. So I had actually met with Dr. Altman at an event that we were both at regarding health insurance. And so he started to talk to me about this. We're leaning towards a very dangerous time where we're having people, you know, having to go to emergency rooms instead of seeing their primary care doctor. So it's actually adding to the cost. And we have a lack of capacity in a lot of our hospitals. They're overstretched, they're overworked. So it's one way both to increase access to primary care doctors and help to reduce costs. of health insurance. And this has gotten widespread support. In fact, our own representative, Greg Schwartz, he's a leader on one of these items, and there's several different parts of these bills. There's 3 bills that sort of all sort of work together, and Dr. Altman is going to talk about that. And a number of other communities have also done resolutions in support of the primary care bills to encourage that they get passed, and that we start incentivizing more medical students towards primary care, that we pay them more, that we create more access, and that we start steering people to a primary care who's available, rather than having them to go to urgent care or use the emergency room as their doctor. So that's just my introduction on that. And Dr. Altman is going to be talking to us about more details. And he must have got stuck in traffic or something. So
Okay, why don't we try to track him down?
okay.
And I think we've just unmuted Samantha O'Reilly from Senator Cream's office. And perhaps you could tell us sort of what's going on in the legislature in general and in the Senate specifically.
Sure, happy to. Sorry, I was really panicked that I wouldn't be able to speak there or be heard. So thank you. Hi, my name is Samantha. I work in Senator Cream's office. Before joining her office, I worked at Dana-Farber and got my MPH. So I oversee her healthcare portfolio, and really happy to be here to speak on this bill. We're big supporters of this bill in our office. Senator Friedman, who chairs the Committee on Healthcare Financing, is also a wonderful colleague to Senator Creams. So happy to speak on the bill or answer any questions. It was reported favorably out of the Committee on Healthcare Financing. And because there's a financial component to this bill, that's a tall hurdle to leap over. So it's great that it came out of committee, and it's currently before the Senate Committee on Ways and Means, which would be its potential last stop before a vote on the Senate floor. Not sure at the moment when that would be, but it's, very promising that it's there. And we're, in our office, Senator Cream's role as majority leader is to sort of work with the Senate president, who has indicated that doing something in primary care is a big priority of hers. So again, happy to, talk more specifically about the bill. I will also just mention that the Senate passed a provision in a supplemental budget around the fair share tax a few weeks ago that allocated spending to relieve debt for students who pursue family medicine and go work in community health centers in underserved parts of the Commonwealth. And I think that this bill would, be an extension of the Senate's current motivation to invest in primary care. Yeah, big supporters of the bill in our office, but happy to chat more or answer any questions.
Okay, before we,
Samantha, thank you so much for being here. I just wanted to ask you, in terms of, there's 3 different bills. Are they going to be all separate, or is there a way that the Senate or when you get them together, will they kind of morph into something different, or one bill?
So I saw 2 House bills and 1 Senate bill. Is that correct? Okay. Yeah. So the House will pass their bills or not, though they will sort of handle the bills that have that code with H in the beginning. I saw Rep. Lawn or Rep. Schwartz might be able to speak to those more directly. The Senate will handle the Senate bills. And then if there's overlap, the bills will then, if they're passed in their respective chambers, go to a conference committee where the differences or anything will likely be ironed out. And then that final version kind of comes together at that stage. But each chamber will be responsible for passing their own version. And the representatives and the senators will, do that independently before ironing out anything after the fact.
Great, thank you very much. And you see that we are joined by two of our state representatives. The chair of the Joint Committee on Healthcare Financing in the House, Representative Long, and I see Representative Incendio.
And I believe, I've got a text from Greg Schwartz that he is now on. Is he on as a phone person?
I can pass to you and see if
Yeah, iPhone, yeah. Ask him if he's an iPhone.
Yeah, doing that now. He is, leaving Arizona, so, I'm glad he could get a signal for wherever he is. We need to let him in.
okay. Well, there's no one in the waiting room.
Okay.
I've asked the iPhone to.
Thanks, Julia.
That's,
I certainly don't want to step in front of Rep. Lon, though, Chair Lon, if he wants to speak first.
okay.
So if you guys can hear me, I hope you can. I'm sorry, I'm joining you from Arizona. I apologize. I'm out with my family on school vacation week, traveling through Monument Valley. I'm just happy that you guys are having this meeting and are supportive of the bill. Hopefully this resolution will pass. Just so you know, the House has two bills on this same topic. The bill that is under my name, 2537, is very similar to the Senate Chair Friedman's bill, but they're all three of them are very similar in their intent and the general impact. And basically what the impact is to try to address this crisis that we're in about primary care. So many of us I know appreciate that it's harder and harder to find primary care physicians. The ability to provide that primary care, which we know is more cost effective and prevents more expensive costs from developing and costly care being delivered, is harder and harder to deliver right now because of the crisis in access. Both the two bills in the House and the bill by Senator Friedman in the Senate would try to address this, and this is not a cure-all, but this is a step in the right direction. Would try to address this by increasing the overall expenditures in the healthcare system on primary care by doubling it in the next 5 years. Currently, the proportion of the total expenditures is 5 to 6%, and most folks who look at this from a policy angle, because of the savings that you get with primary care and the prevention that you get, that the belief is that a healthy system would be more in the range of 15%. So we're talking about 6% versus 15%, and the goal of these bills is to try to get us at least on the path to improving and getting closer to that goal. Why does that matter? It matters because the degree of support for primary care right now in the way that we pay for healthcare and what we spend on healthcare is not, and this is because so many people are leaving. So many people are leaving the profession. More than 50% of primary care physicians are over age 55. Many of them are retiring early. If they're not retiring, they're switching to concierge practices where they charge people a significant fee, whether it's $5,000, $2,000. Some charge $10,000 per person on top of the healthcare insurance reimbursements that they get just to be in their practice. And what this is doing is it's reducing the ability of people to find primary care physicians. So what this bill and the other two bills would do is set us on a path to increasing that total expenditure, the proportion of that total expenditure on primary care. I guess I should add that the primary care task force, which was created by the law that was passed last session by Representative Lon and Senator Friedman, set up a primary care task force to look at the problems in primary care, and they have reported out a recommendation to do exactly what these bills do, which is to try to increase the overall expenditures going to primary care closer to twice of what it is now over the next 5 to 8 years.
Can I ask, are you in danger of losing your signal?
I am right now looking pretty good, but we are on the road, so I could lose it.
Okay.
The answer is yeah.
Okay,
I'll
maybe
stay on as long as I can.
if we have any questions for Representative Schwartz, we should ask them now.
What, if I may,
Sure.
I do have a question. I don't know if this is best answered by Representative Lon or Schwartz, but you say we're trying to incentivize or increase from 6 to 15% the expenditures on primary care physicians. I'm curious as to what, and maybe there are different mechanisms in the different acts here, but I am curious what the mechanisms are that are going to achieve that, just at a high level. I don't need all the detail. I'm just curious.
Well, that's a really, really astute question, John. The difference between the two House bills actually is about how you get there. The Senate bill and my bill would both do it through the current insurance system, and how it would have the Department of Insurance and Mass Health, which is its own insurer, or basically change the offerings in their insurance portfolio to include a primary care option that pays more for primary care and is a higher reimbursement, and as a result provides the ability for providers, whether it's hospital systems or individual providers, to provide
You went,
practitioners, physician assistants, and others, and not so much the salary that they're going to get, but it's more about the lack of support that they have in the clinical setting that they're practicing. And that's one thing. Higher reimbursements and more spent on primary care as a whole will do. It would lead to better support in the practices, better ability to provide the services that patients need, and the ability to work. My other was in house. Yeah.
Greg, we're not really hearing you anymore. It's breaking up quite a bit, unfortunately.
you must be behind a monument.
It's like he's behind the moon.
I don't know if you can hear me now, but I'll try to explain that the second mechanism is to do it through a provider tax, and a way of raising money from all the providers and payers in the system, putting it in a fund that then would redistribute it to the providers by a central body.
Okay, would Representative Lon like to add anything if you're on there?
Sure, I'm here. Thank you, Rep. Schwartz, for making that effort from Arizona to get into the call. I really appreciate it. And I've got to work very closely with Rep. Schwartz and Rep. Sangiolo on this issue of primary care that Rep. Schwartz just explained. In the legislation that was passed at the end of last session was legislation that I was involved with in the Healthcare Finance Committee to set up this primary care task force to really tackle the issues around primary care. As we know, and I really want to thank Samantha O'Reilly and her office with Senator Cream, because Senator Cream obviously has a very big leadership role in the Senate and is very influential and been very involved in this issue of primary care with Senator Friedman, who is my co-chair on the Healthcare Finance Committee. So they, just put some money in for education for primary care doctors. I believe that was in the Fair Share Amendment that was just passed. And these bills that have been passed that Rep. Schwartz was just talking about are very similar. We said it's just about how we can invest more in primary care, and also how we can support our primary care doctors. It's not just about investing more, but we're trying to invest more money in primary care without adding more money into the system. And so that comes to, which what we just passed was what's frustrating so many of our primary care doctors who are trying to work and take care of patients is the constant turnover in coding and the Epic system, and spending so much time fighting with insurers on prior authorization. So we just relieved a lot of those, and that the governor had put forward just a couple months ago, is to really take away some of those prior authorization frustrations for our primary care doctors. Because if we go to our primary care doctor, they shouldn't be fighting and spending most of their day on the phone fighting with our insurers about if that test that they ordered should be reimbursed. So that's one of the real big frustrations of primary care. And as Rep. Schwartz says, I mean, we're really fortunate to have Rep. Schwartz, and especially filing this bill with his expertise, being a primary care doctor, being very involved in healthcare. And Rep. Amy Sangillo has been so involved in this, because it's one of the biggest focus right now in healthcare, is trying to support our primary care doctors and the profession. So I also had filed another bill called the Hire Act, which is to assess private and college endowments a one-time 2%, which would put the money into a healthcare workforce trust fund to pay tuitions for all of healthcare workers, especially primary care, where we need the doctors who have made it so hard for our primary care doctors to go to medical school. And as Rep. Schwartz says, we're seeing so many of them leave the profession from being frustrated with dealing with prior auth, coming out of college and medical school with high loans and going into this profession. And many of them often go into a specialty because they can't afford to stay in primary care, when so many dedicated people want to do this work and take care of people at this level. And we know from all the research that goes on that if you go to your primary care doctor, that is how we prevent people from getting sicker and showing up at our emergency rooms at very high cost care. That is the highest cost care that when people show up at emergency rooms. And we know that we do not have enough primary care doctors, and we need to support them. But we're trying to do all that. So I'm on a primary care task force with Senator Friedman, with probably about 15 to 20 other of the big stakeholders, experienced stakeholders in healthcare in Massachusetts, from our payers, our providers, primary care doctors in our hospital systems, at our community health centers, Senator Fried and myself. It's chaired by Secretary Kiami Manaya, who is the Secretary of Health and Human Services, and he co-chairs it with David Seltz of the Health Policy Commission. So we've been meeting over the last year and a half, every 5 to 6 weeks on the primary care task force to come up with recommendations. So these bills, to answer Allison's question, like when you have bills like this, Allison, you can pull things from different bills. They carry bills, so those all can be added, and that's what will happen. I am working on a pharmacy benefit manager bill. Senator Friedman, it will probably go first to do the primary care bill, and then the House will take up the primary care bill, and the Senate will probably take up the pharmacy benefit manager bill. So that's what has been the real focus of the legislature, is working on primary care. I think the governor, the Senate, and the House are all aligned. If you listen to the governor's speech at the State of the State at the beginning of the session, primary care was a major focus. We know we have to support our primary care doctors. We know that we have to get, we don't have enough of them. We know that we need to support them, but we also need to do that without raising the cost of healthcare. So that's why we need to be able to cut some of this, really the administrative costs that are happening, that are really a cost of the system. And that's the prior authorization that really can really frustrate our primary care doctors in those primary care settings. So that's a little bit about some of those bills, but so there's the Rep. Schwartz bill, and there's another House bill filed by Rep. Haggerty. So those bills will be done after we get a bill from the Senate that Senator Friedman has sponsored and has been very active over the last several terms on primary care. So I'm happy to take any questions.
Any members of the committee with questions? I've certainly got some.
Yeah.
Councilor Farrell.
Thank you. I just first and foremost want to thank all of you for your efforts in this extraordinarily complicated area that you're dealing with. I've had a lot of experience with primary care physicians, and they need all the support they can possibly get. So thank you for what you're doing.
Thank you.
So maybe I'll ask some of my questions. So it seems like the path forward is that you would be sort of led by the Senate bill, and whatever passes the Senate, then the House would try to match that by combining elements of the two different House bills. Is that the scenario?
Yeah, correct. That's a good question. It's so the Senate will probably go first on primary care. And so when Senator Friedman goes, the bills in the House are very similar. One of the real is about how the trust is set up, about basically paying our primary care doctors out of this trust so they get money immediately. There's a lot of other parts about capitation rates and how we pay our primary care doctors, trying to get them money sooner. So waiting for, waiting far too long for billing. And also those two House bills, there'll be different parts of that be taken up. There'll also be amendments to it. So that whatever the House bill final will be sent to this, that will be passed in the House, the Senate will pass their bill, and then it will go to a conference committee for the differences for us to iron out between the House and the Senate to work on the differences to agree on a final bill that we would then send to Governor Haley. So there can be different aspects of both bills on how we, sort of like payment, and there'll be certainly differences in any bill. The House and Senate will have some differences that get ironed out in a conference committee, which I would be chairing on the House and Senator Friedman in the Senate.
And is it likely that these bills would get voted out this term? I'm just wondering, if we're going to endorse something, does it make more sense to sort of endorse the concepts included in the bills rather than specific bill numbers without knowing which?
I mean, I think you could certainly endorse all the bills because they're very similar. I think because it is the concept that we need to invest in primary care. We need to support our primary care doctors, and we need actually to also really strengthen the workforce. The governor just appointed me to a healthcare affordability board, and I am co-chairing the workforce part of that. And so that is another board that I am on that is looking at how we can also really work to get more people into primary care doctors and keep them in primary care and support them. And that is through support, through working through some of these frustrations that I said that, with prior auth, and also working in a lot of things with tuition reimbursement and having some of those tied to staying in primary care with the incentives of staying in primary care for a certain amount of years here in Massachusetts. So I think you could endorse all the bills because they're very similar.
Because I know I did my best to try to read through them and see what the differences were, and I know there were differences in numbers. I mean, I think two of them have a goal of making the percent of primary care as a total of the healthcare spending to be 12% over the 3-year period, and the other one is 15%. And then there were different numbers on how many metrics to use and so on and so forth. But the concept of the monthly payment instead of the fee for service item by item, I presume that has great appeal to doctors who are just tired of the paperwork and having to have an office full of.
Right. Which they would work with the payers on a pay per patient per month on the capitation rate, and so that's one of the key focuses in all of these bills.
How would this affect Medicare Advantage, and for that matter, entities like the City of Newton, where we're self-insured as to the expenses? We have Blue Cross doing the administration, but would we be treated like a health insurer
Yeah, and so they can opt into all of this. Self-insured plans, that's one of the big issues, that you can't force a self-insured plan into anything, and that's actually one of the biggest challenges of like a program like Medicare for All. If you're self-insured, you cannot force a self-insured plan to do anything, but most of them will follow if obviously it's going to be a savings to them.
Okay, Councilor Charm.
Yes, thank you. Thank you all for joining us. I really appreciate you taking your time to explain this and represent the issue, and also all the time that you spent in many committees looking into this. Something that is a huge access and cost driver for so many of us. I have 3 questions. So if we want to bounce around, feel free. But my first is actually a very sort of like tactical question, which is why is like the state Senate and the state House are going through many different bills all the time. Why is it important that the Newton City Council endorse these bills versus others? Like, why are we having this conversation at the Newton City Council tonight?
Would you like me to take it?
Sure.
So, Councilor Charm, we have one of the reasons that we're doing the resolution is just to show that our city's support for this, for more access to primary care, and figuring out the difficulties of people getting access and the costs. And I actually had been I've been involved in healthcare issues for a couple of years now, and I've been seeing things coming and becoming increasingly dire. And one of the things that really made sense, actually, our speaker who's on his way, he just was doing a lecture, so he's running a little bit late. I ran into Dr. Altman about this, and he was talking to me about his support for primary care bills. And I understand that many other communities have also supported, have done resolutions in support of this. And it's a way to influence our legislators. Dr. Altman, thank you. Please have a seat.
Thank you.
Dr. Wayne Altman has just arrived, and he will be doing a presentation, and he could probably also answer some questions about it. Dr. Altman, I was just talking about why we're doing this resolution here in Newton and why it's important. And maybe you also want to add to it. I was talking about how it's such a critical issue that we wanted to support our legislators and make sure they advocate for better access to primary care, and it helps reduce costs, so it'll benefit us all.
Right on. I don't know if there's time for the slides or if we want to skip past that.
Well, I think there would be, but I think we're sort of we have some questions right now, and okay. Perhaps we could start with that and then go to the slides.
How long a presentation is the slides?
10 minutes?
Yeah, sure. I think we should do it.
Okay, so yeah, why don't we get the presentation, because that might answer some questions, might create more questions.
Great. Well, why don't we start the presentation and then we can come back to you, Councilor Charm.
Is that
it was there.
Oh, I think we have Councilor Mickley. Did I see Councilor Mickley's hand?
Yeah.
Yes.
Yes.
Did you have anything you wanted to ask right now?
No, just to briefly answer Councilor Charm's question, then pass it off to Dr. Altman. Yeah, usually I'm not in favor of engaging resolutions that don't have to do with the work of the city of Newton. We have enough things to focus on. But I met with Dr. Altman, heard his reasoning, spoke to Representative Schwartz, heard his reasoning, and basically, long story short, healthcare costs affect city budgets drastically. So it seems like something that does affect us. And without getting too much into the details of actually pushing forward specific legislation, the idea of investing in primary care seems like something that will help the city of Newton. So that's why I supported it. Thanks.
And Councilor Charm?
My other questions are more about the substance. So if we're going to go to the presentation, then happy to do that. And then we can take those questions afterward.
Okay. So I think we're queuing up the presentation here.
You're at the end, so we should just, yeah, thank you so much.
Can we sort of maximize it on the
Yeah.
screen? Great.
Hey, amazing. All right. Thank you all. It's an honor to be here with you all in the city of Newton. We're talking about legislation that we call Primary Care for You, or PC for You. We've been at this for close to 8 years. For much of that time, we've been working with the chairs of healthcare financing on the Senate side, Cindy Friedman, on the House side, John Lawn. And next slide, please. This kind of answers, I think, some of the question that you were just talking about. Right now, I think you all know that primary care access is abysmal. Good luck if you lose your primary care doctor trying to find a new one. Even if you have a primary care doctor, good luck trying to get an appointment with your primary care doctor. The supply is inadequate. The cost is exorbitant. And Councilman Mickley was saying that it's a little bit outside of the city of Newton, but in fact, it also directly affects the city of Newton because you pay an exorbitant amount of money for healthcare in the city of Newton, and you should pay less. And imagine all the things that you could do that you're not able to do because you're spending so much money on healthcare. A lot of that money going towards waste, and we'll talk about that. There are huge health disparities. If you look at Back Bay and Roxbury, 2 miles apart, 23-year life expectancy difference, which is shameful. Primary care docs are going to direct primary care and concierge, making this access crisis worse and worse. And the medical students aren't coming to save us. We just had match day where all the medical students find out where they're going to do residency. And of the 700 medical students that graduated last month, 4% went to family medicine, just 4%. And we're going to talk about why they're not coming to save us, because they know that there's probably, we got to fix the job and fix the pay before medical students are going to want to come. Next slide, please. So the Health Policy Commission did a report in January of 2025 about primary care. They entitled it A Dire Diagnosis, which indeed it is. Next, please. This is something that you all probably know, that the amount of money that families, employers, employees, municipalities are contributing to healthcare is going up at a dramatically higher rate than inflation or median household income. I think we all feel that. Next slide, please. So a third of primary care docs in Massachusetts are over 60. They're retiring soon. Some are not even waiting till 60. They're retiring early. People are leaving the profession. People are decreasing their hours. They're shifting to concierge or direct primary care and dramatically decreasing their panels. Next slide, please. And every time somebody does that, it leaves the same work behind for the rest of us, which increases our burnout, which creates this vicious cycle. So we need to replace this vicious cycle with a virtuous cycle. Next, please. We just talked about that. Next slide, please. So this is a true crisis. And for those of you who speak Mandarin, you know that this is the word for crisis. Next slide, please. But what's interesting is when you separate the two characters, the two letters, if you will, it means danger and opportunity. And we are in danger with primary care dying, okay, if we don't do something. And there's a real opportunity to make a difference with this legislation. Next, please. All right, so here's what we're trying to accomplish with this legislation. I like to call this the primary care triple superpower. Primary care is the only aspect of healthcare that improves health and increases equity while lowering the overall cost of care. You get more for less. And yet, in our infinite wisdom, we only invest in Massachusetts and nationwide about 5 or 6 cents of every dollar on healthcare dollar on primary care. Our peer nations, 15 cents for every dollar is invested, with way better outcomes. Okay, so how are we going to achieve this primary care triple superpower? By doing the following 6 things: doubling primary care investment in Massachusetts, paying primary care clinicians per patient instead of per visit. When you go see your primary care, they're running around like a chicken with their heads cut off because they're pressured to see like 20 or 30 patients in a day. That will shift. Now you can take care of patients. You don't try and have as many office visits as you can in the day. No co-pays and no deductibles with primary care. Financially incentivizing better primary care. I'll explain that in a second. Removing health insurance from primary care. It turns out health insurance never belonged with primary care. Think about insurance. It's for catastrophic and unexpected outcomes. There's nothing catastrophic or unexpected about primary care. Those are not insurable events, okay? And this number 6 has already happened through statute, the establishment of the Massachusetts Primary Care Task Force. Chair Lon, who I saw is on the Zoom, is one of the 25 members, along with myself, Senator Friedman, and 22 other folks. Next slide, please. These are all the folks on the Primary Care Task Force, these 25 folks, a lot of different stakeholders, from payers to hospitals to primary care docs to NPs, PAs, social workers, business, etc. Next slide, please. We're not alone. There are 20 other states approximately that are trying to double primary care investment. They're all at different stages, trying to do it in different ways. We're a little further along than most of them. Next slide, please. These are what we call the primary care transformers. This is how we financially incentivize advanced primary care, better, higher quality primary care, through doing all of these things that we would love to do in our office, but we don't get paid to do any of those things. So each primary care office will do a few of these things and lose money doing it because they think it's the right thing to do, and they out of the goodness of their heart offer these services. But we need a system that supports doing most of these things. Next slide, please. So this is the payment model. You look at the baseline of what primary care practices were getting paid, and then you double it. And then you adjust from that number up or down based on how many of those transformers they've adopted, the quality of care they're providing, and how complicated the patients are. We don't want to unintentionally incentivize doctors to cherry pick and say no thank you to more complicated patients because they're getting paid per patient. So you pay them a little bit more for more complicated patients, a little less for less complicated patients. That risk we're talking about, that complication, is not just medical risk, it's also social risk. If someone has food insecurity, housing insecurity, job insecurity, that makes them also a more complicated patient. And there's some easy ways through census data to identify that level of risk without burdening folks. Next slide, please. So this is Massachusetts, 7 million people, 4 million of commercial insurance. Those are the two shades of blue up there. What's interesting is that 60% of the commercials are self-funded, which means it's an employer-based plan. The employer is insuring their employees to try and save some money, except there's a law called ERISA that says that the government can't tell self-funded plans what to do, okay? And so if we pass this brilliant payment model that I just showed you, the dark blue 2.4 million people can say, no thanks, not interested, and they're not required to do it. In which case, this law would only affect about 1 in 5 folks from Massachusetts, 1.6 million people. This is exactly what they did in Delaware a couple of years ago. And they were hoping that the dark blue would come along for the ride. They didn't. And now Delaware is really feeling disappointed that they haven't moved the needle at all. We've got a solution for this problem. Next slide, please. It's called the Primary Care Stabilization Fund, or the Common Fund. And this is a primary care fund that is run by the Health Policy Commission in the state of Massachusetts that pays money directly to primary care practices after collecting it from the insurance companies. The insurance companies have collected the money and then they deliver the money, but they stay out in terms of how the healthcare is administered and delivered. All of the administrative waste that happens with an insurance company goes away, in part making things way less expensive by losing that administrative waste. And you bypass the federal ERISA law that allows you to include the 2.4 million people that were excluded just a moment ago. Next slide, please. So Albert Einstein said the significant problems we face can't be solved at the same level of thinking we were at when we created them. If we want something different with healthcare, we have to do something fundamentally different. And that is this. Next slide, please. There was a primary care summit in Sacramento, California, a couple of years ago. 30 of us were summoned to Sacramento to solve primary care. Spoiler alert, we did not solve primary care. But this man, who was the keynote speaker at the end, who summarized everything, Dr. Kevin Grumbach, said that there are many proposals he's heard of, but they all have fatal flaws. Delaware didn't include the self-funded folks. California said 15%, but it's optional and it's a 10-year ramp. So how's that going to work? He said the only program or proposal he's heard that doesn't have a fatal flaw is primary care for you in Massachusetts because of this primary care fund. And he's proposing it in California as well. I'm going to propose to Governor Healy that she bets Gavin Newsom to see who can get it done first. She lost her last bet with the governor of Washington on the Super Bowl, unfortunately. So hopefully she could win this one. Next slide, please. So 11 different states have reached out to us asking about this primary care stabilization fund so they can pattern their own legislation after this concept. We think that this can become a national model in the same way Romney Care turned into Obamacare. Next slide. So of course, the elephant in the room is how do we pay for this? I'm sure half of or all of you were wondering that as we were talking about this. How do you pay for the doubling of primary care? Next slide, please. Well, it turns out that about 40% at least of every emergency department visits didn't need to be there. Emergency department visits are very expensive. There's an old joke that the CAT scan is the 5th vital sign in the emergency department. That is not a slight of emergency medicine physicians. They will never see this patient again. They don't have a relationship with this patient. They need to do what they need to keep that patient safe. But I'm a family doctor. I have a relationship. I will see them again. I don't need a CAT scan. I just need the capacity to see these folks and save ridiculous amounts of money. Okay. I went to the emergency room at Leahy a couple of years ago. My wife summoned me there for her mom who was sick. There were 85 people in the waiting room waiting to be seen. I felt like I just could go around and start doing rounds and help people go home. My wife said I couldn't do that. So we think that you can save enormous amounts of money by reducing unnecessary ED visits and hospitalizations. And we, next slide, we consulted a national firm to do a simulation, and they told us conservatively in 40 years, the whole thing is paid for, okay? And in the next 10 years, next slide, $1.6 billion of savings, okay, for the Commonwealth. Both of those numbers are conservative. A lot of experts have told me that 4 years is ridiculous. It'll be closer to 1 to 2 years, and that the $1.6 billion, it will be double or triple that amount of savings. Next slide, please. These are our 30 endorsements. We have got the Massachusetts Medical Society, UMass Memorial Healthcare, the community health centers, nurse practitioners, PAs, primary care docs. On the bottom right, you can see 4 municipalities, Boston, Worcester, Springfield, and Cambridge. I think we have room to tuck Newton right in there. Next slide, please. Governor Healy has been talking about primary care and the need to invest in primary care. There's never been so much talk about major legislation in primary care as there is now. From the Senate President, Chair Lawn has been talking about it, and the governor's been talking about it. The Secretary of Health and Human Services is a family physician. Next slide, please. So there are 3 primary care bills that we're talking about. We're asking you not to support one particular bill, but to support the concept of primary care for you, which is embedded in all 3 of these bills. The original bill was Senator Friedman's bill, S-867. Representative Schwartz's bill is very similar to Senator Friedman's bill, but adds Medicaid spending for primary care residencies, which was a great idea until Trump's big bill, in which case that may be more challenging now. And Representative Haggerty's bill, H1370, is similar to Senator Friedman's bill, except it's the only one with the primary care stabilization fund. All right. And so when these bills pass in the House and Senate and come to conference committee, they come together to form historic landmark primary care legislation in Massachusetts. Next slide, please. So ultimately, when you look at healthcare and the problems of our system, the problem is that the overarching force in healthcare is profit. Profit is what's determining our outcomes. With this legislation, next slide, please, we can at least maybe get health and equity on an even playing field with profit. Next slide, and next. And that's it. I don't know if I made 10, maybe 12 minutes.
That was good.
Okay. Very good.
Wow, that was great, Dr. Altman.
Thank you.
The detail that you were able to get into there. I'm just curious why it hasn't happened sooner.
Oh, God, really?
It's if you've been working on this for 8 years already.
Where is the pushback?
Well, there are systems and institutions that are doing quite well.
Yeah.
And when you're doing well, you're resistant to change. But in talking with the health insurance companies, both Blue Cross and the Massachusetts Association of Health Plans, they're starting to come along and be supportive of this. If not outright supportive, we think that they will come to neutral and not oppose this. Some health systems have supported this. Others who are bigger and richer might push back. But this is this is not a Band-Aid. Most health policy changes in the last 10 or 20 years, we're literally rearranging the deck chairs on the Titanic as things got worse and worse and worse. This is a fundamental change. And you all know how difficult fundamental changes can be policy-wise. But it's time. People like to say the bubble's going to burst soon. No, the bubble has burst. This is what it looks like after the bubble burst. $29,000 for a family of 4 to get health insurance per year. That's outrageous.
I have a question if no one else does.
Okay.
I was intrigued about your point about primary care shouldn't be involved in health insurance at all, because it's a regularly scheduled visit, and that really intrigued me. So would that be part of this? Would people just be able to go to their doctor? There'd be no copay, no cost to them whatsoever. And would that also would bring to the next question, would that be a capacity issue? At some point, we're going to have to catch up to have enough primary care physicians to get, because we basically want more people to go regularly to see their primary care doctor.
Okay.
So it's almost like a little chicken egg.
Two great questions. So what we're proposing is primary care as a common good, almost like a utility. Like you turn your water on, you expect water to come out of the tap. You turn a light switch, you expect electricity. We're talking about primary care in that concept. Okay. We have just written an article, myself and 3 colleagues, including Dr. Grunback, who you saw up on the slides from California, about this concept, primary care as a public good. And it is going to be published next month in JAMA, the Journal of the American Medical Association, arguably the most prestigious medical journal in the world, was totally intrigued by this concept, as you are, and is publishing this article next month. With that said, you raise a good point. I said for the medical students, we need to fix the job and fix the pay. Well, this legislation does that. But if it does it perfectly and you do it right away, you still have to wait 5 years before they're like fully minted and ready to add to that capacity. So what happens in the meantime? Well, when you have this robust team through those transformers and you're paying per patient, not per office visit, it creates this increased capacity. And by the way, it stops the bleeding. People stop leaving, stop going to concierge. So it stops the bleeding of people leaving, and it adds capacity through teams and through a prospective monthly payment instead of a fee-for-service payment mechanism in the short term.
Councillor Charles.
Thank you. There could be so many questions. I just want to acknowledge, there could be so many questions about the technicalities and all of these things. But I am curious mainly about 2. The first is, as we look at, doubling the amount that we're, the amount of our statewide healthcare spending that's supposed to be going into primary care, like, what does this mean on an individual primary care physician level? Like, are we basically saying we want to make sure that every PCP's income is doubled in the coming years? And also, like, what does the research show about how much it needs to be to actually be making a difference in terms of attracting people in the pipeline into primary care? Because as Representative Lon and others have noted, like this is just one lever out of many, including like, the amount of paperwork and the amount of time they're spending on the phone and, all of these different parts of the problem. And so I'm curious, like, what is the financial lever, or what is the financial goal for an individual PCP that we think will actually help to like make the gears start to move in the right direction? And how far does this get us?
Okay, so you're talking about the magic threshold that it would
Yep.
take.
Yep.
Medical students starting to come into primary care and family medicine. Well, it's interesting. Your second question was going to be how I answered the first question. So well done. There was a study done about 15 years ago that looked at the average family medicine salary divided by the average specialist salary as a ratio. And that, like anything, ebbs and flows and goes up and down, okay? And then they looked at medical student choice into primary care. And the two lines were parallel. They went right with each other. I had a colleague in my kitchen about 15 years ago. He said, Altman, it's not that complicated. It's the money, okay? And so to answer your question, when you get to 70, that ratio gets to 70%, medical students flock to family medicine. Okay, you've got to get to 70%. Where are we right now? We're at about 55%. Okay, it wouldn't take much of an increase. You do not need to double family medicine salaries. Okay, if the average salary is in the 200 to 250 range and you added $50,000 to that salary, okay, the rest of the money is going to go to all the primary care transformers, all those systems that improve the quality of care being offered to the patients. But a little money can go towards increasing the salaries just enough to move that needle exactly as you described.
Okay. Thank you. And I had a second question, but I will lower my hand until it comes to me.
I'm not going anywhere.
I have just one more follow-up. Dr. Altman, are you saying that so like a specialist would make, say they were making 250,000 or so.
Say 500.
500, okay.
Yeah.
So the primary, you're saying that when you're saying using those 55% and 70%, you're saying they're making 55% of what a specialist would make, and we're pushing to 70% of what a specialist would make?
Let's say the numbers are 250 and 450. That's a ballpark. 250 for average family medicine salary, 450 for an average specialist salary. That's about a ratio of 55% where we are, okay? You add 50,000 and 250 goes to 300. Now you, just with that 50,000, you've got to 67%. You're just about there.
And is that because people who are interested in medicine really want to be family? They want family care. They enjoy that. That's something. I mean, you have an ongoing relationship with these people for years and years. That there must be some real fulfillment to it that would make it appealing. Is that?
I've been teaching at Tufts Medical School for almost 30 years, and so I've had relationships with hundreds of medical students over the years, and so I've really gotten a sense of they come into medical school incredibly idealistic and want to do-gooders. They want to make the world a better place. And medical school, unfortunately, predictably hardens people. It's the wrong direction we're taking people in. We're trying to figure out how to go the other direction, increasing compassion instead of decreasing it in medical school. But that's a topic for a different day. But the point is that they come in feeling really excited about the relationships and about the moral high ground that we are on in primary care. And by the time they get to third year and they do rotations and they see the primary care docs running around like crazy people, they literally will look at you and they'll say, boy, you're doing God's work. Good luck with that.
Yeah.
If you fix the job, they no longer need to say good luck with
that. Councilor Farrell.
I don't necessarily have a question, but I have, if I may say personally, 32 years of experience with the medical professions. I had a heart transplant 8 years ago, but leading up to that, many years of getting there. The difference, I think, basically between primary care physicians and surgeons, I don't know many surgeons that I've met who would make great primary care physicians. They are seen to be very directed. They come in and look at a patient and say, there are 6 steps to solving this problem, and they go on, but the bedside manner is like, and I don't, no disrespect to them. We need them, and they're extraordinarily talented. But just the relationship between those extremely talented people and the people who want to be primary care people, I think it's like, why would some people with great mathematics backgrounds want to be a teacher? Because they could go make a lot more money in private industry. I don't mean to be simplistic about this, but people who want to be primary care physicians are just of a different mindset, I think. But they aren't being paid well. They aren't getting the support they need. And I think it is true, having sat in many emergency rooms, the number of times that I've been there and seen people like, I need to get and see this doctor. Why are they sitting there doing this? And I talk to people I know. We need to get them out of the emergency rooms. And
It's not good for anybody.
no, for anybody at
It
all.
hurts the people who are having real emergencies.
Right.
It hurts the system because of the expense. It hurts the people who are sitting there who need to be with their primary care doctor who knows them.
Right.
And by the way, I could tell by looking at you that you had a good heart.
I appreciate you. I wish I knew who the donor was. But,
I think, Counselor, Charm thought of her, other questions. Okay.
I knew
I
it.
did. I did. It came back to me. Thank you for your patience. So my question is more on the compensation per patient side. And I think we've all experienced some of the difficulties of, trying to get on a list for a new primary care physician. I actually moved to Massachusetts about 5 years ago, had to get all new doctors for everyone in the family. And, when I was looking for primary care physicians, you have a hell of a time, right? Trying to find anybody. I had to make an appointment 15 months in advance to meet with a primary care physician. And then after I met with that primary care physician, she told me on the day of my visit that she was leaving the practice and moving out of state. And then I got a call from the practice saying, oh, do you want to stay with us and, stay with one of our doctors? And I was like, I don't know. That I was recommended to go to this one specific person by people who knew something. So my question is on using my situation as an example, when would I count as a patient that physician would be paid for? Would it be the day that I called and made an appointment, and so they would be getting a monthly payment for those 15 months that I was waiting to be seen for the first time? Or, would it be only after I come in? Would it be, with the practice, once that physician left, or would they still be getting a monthly payment, even if I hadn't come back in to have a second visit? I feel like because we know that there are so many huge cracks in the pipeline of actually seeing people, I wonder, where have you guys pegged it so that it's as accurate as possible?
Yeah, you're a very deep thinker about health policy and health systems. This is the word that you're asking about is called attribution. How do you attribute a patient to a practice? Turns out it's a very complicated concept. In the legislation, the way it's written is for there to be a primary care advisory council, which would essentially be a continuation of the current task force, and for there to be a primary care office in the Health Policy Commission that is advised by that council and would determine the system of attribution. And they would get into the weeds on that. It turns out that it's not a good idea to legislate that level of detail because those things change frequently, and you don't want to have to change the legislation every time those things change. And so one of the things that it says in the legislation is to lean on the systems that Mass Health is using to try and be consistent with Mass Health, because Mass Health does a really good job and has thought deeply about attribution. So we would lean on their attribution models and figure out how to do that. I will add that you had one method, the wait forever until you find a PCP and then they leave you. That's one method. The other method is I give up. I'm just not going to have a PCP. That's a common one. And then the third one, if you're lucky enough, is you know somebody who knows somebody and you call in a favor and then a doctor makes an exception and allows somebody onto their panel, which of course is lovely for the person who gets that favor, but a completely inequitable system.
Thank you.
I had a few questions. You just mentioned the word panel, and I saw that in the language of the bills. So patient panel kind of refers to the portfolio of patients, essentially. So I was wondering, is there kind of a bright line of what is in primary care and what is other than primary care? And I'm wondering about things like, you know, your sort of screening mammograms and colonoscopies, drugs. Are they outside of primary care, or are they in primary care, but only if they're prescribed by the primary care doctor? Because these targets, whether it's, say, we're trying to get from 5% to 15% of expenditures being primary, what's in the denominator that we're kind of racing to outpace?
Right, really good question. So it's a very controversial topic, how you define primary care. Some people like to do it by the specialty. Oh, it's the internists, the pediatricians, and the family doctors. Maybe the geriatricians too, probably. Some OBGYNs would say, well, we do some primary care.
Exactly.
Right? Other people do it by the code that you bill for. Certain billing codes count as primary care, certain don't. There are about 5 different definitions around the country. There's an organization called Milbank that put a definition together. Oregon put a definition together. Washington State put a definition together. California did. Well, CHIA in Massachusetts has put together a definition.
CHIA?
Center for
Health Information and Analysis.
Yeah.
Between the two of us, we can put it together. CHIA presented to the task force their definition, which was very similar to Milbank. I don't have the details of it, but what I can tell you is that when they presented it, it sounded eminently reasonable. And there is no perfect definition. No matter how you define it, somebody's going to come along and say, but what about, right? And then if you do, okay, oh, that's a good point, we'll do it your way. Then the other person says, but what about that? And so there is no perfect definition. You need something reasonable, okay? And what's interesting is the OBGYN issue, for example. If you say, fine, we're going to include the primary care that OBGYNs do, it adds a teeny tiny sliver of money. So it's like, whatever, it doesn't matter. You want to do it? Sure. You don't want to do it? Fine. Doesn't really make that much of a difference when you add that on. And so what the primary care task force decided is, but the same concept of not legislating in the weeds of attribution, is that we're not going to legislate the definition of primary care, because if we want to change it, you need new legislation. So we're going to legislate that CHIA is in charge of creating the definition of primary care, and that the Primary Care Advisory Council will advise them on that and changing that as needed over the years to come.
And I asked this question earlier, but where does Medicare and Medicare Advantage fit in?
So it turns out we are not in charge of Medicare. There's some other gentlemen, and they're nothing if not gentlemen, are in charge of that. So the idea here is that this model, by the way, I didn't tell you this, but we spent 2 years putting this payment model together. At the same time we were doing this, Mass Health was putting their payment model together that formed their 1115 waiver and their primary care payment model. When we were both done, we met to compare notes. And it turned out 2 groups of people who worked completely independently came to almost the exact same place. The concepts in Mass Health are virtually identical to the concepts that I just shared with you. Okay? So when this legislation passes, this and Mass Health just come together. And then when this presidency passes, we can have a demonstration project with Medicare where they'll allow us to have one overarching payment model for the entire state. And then it essentially becomes a single payer for primary care.
That's the next resolution.
From your lips to God's ears.
Now, I'm not talking about single payer Bernie Sanders style. Not that there's anything wrong with that, to quote Jerry Seinfeld. Okay, I'm talking about single payer for primary care as a carve out. I've been a big fan of single payer overall since it was presented to me in the 1990s when I was in medical school. I said it makes way too much sense. Okay, and yet 30 years later, we have not moved the needle. So instead of focusing on single payer for the whole system, why not focus on taking a huge bite out of the apple and having single payer for primary care, the aspect of healthcare that where it makes the most sense to have a single payer and to not have insurance involved, as we discussed.
And what you show, however, is the money is there.
And there's plenty of money in the
It's
system.
just, right.
We don't need to add more money into the system.
Right.
I would say we pay more than probably any place in the world.
Correct, double the second place. Second place is Canada,
It's
and we're double.
Senator Friedman, the chair of the Senate Joint Committee on Healthcare Finance. I remember her asking, "Where is all our money going to?"
Yeah.
Because what did we spend? $78 billion last year on healthcare.
A ton of it goes to administrative waste.
Yeah.
I see, Councilor Greenberg has questions.
Oh, thank you. Thank you, Dr. Altman, for the presentation and all your hard work on this critical issue. And I want to thank all our state reps and Senator Cream's office for working on this also. I wholeheartedly, and also want to thank Councilor Leary for bringing this resolution to the City Council, which I wholeheartedly support. Many of you know I work at Newton Wellesley Hospital, and I see firsthand every day our emergency room being overwhelmed. We have patients, critical patients, sitting in hallways in the emergency room, waiting for hours. I was once one of those patients, so I experienced it firsthand. It really needs to be addressed. And I also have experienced as a family losing our primary care doctors. Myself, my husband, my son waited months and months and months for a primary care doctor, only to find out months later that they either became a concierge or left. It's a common problem. And even though I work in the healthcare system, I have more advantages than someone who perhaps is an immigrant who doesn't speak English. So it's a very important problem that we need to address sooner rather than later. So I hope we all sign on to this resolution. Thank you.
Thank you so much.
Councilor Oliver.
So to that end,
Yes.
I'd like to move approval on the resolution.
Okay. Is there any, I just, I have a few copy edits.
Your copy of it? Okay. The first one is Senate 867, which number?
There was a reference to, I think a different in the presentation, there was a different number.
There was a previous bill called S850. S867 is correct.
Okay, so we want to make sure we have the current number.
We do.
Yeah, okay.
And then whereas the 2021 National Academy of Science, Engineering, and Medicine issued a report. So
2021.
In 2021, so it's redundant.
Oh,
Yeah,
okay,
I
yeah.
think the
Lose
first,
one of the 21.
I think lose the first 21, lose the first 21.
Yeah,
Okay.
sounds good.
Um,
Sciences and Engineering is like you're asking for a little A in there.
or something, yeah.
Academy of
A
Sciences,
comma or something like that.
Engineering, and Medicine.
The comma's fine.
Okay, well,
But not an Oxford comma. Okay.
and then your last one is Senate. Oh, I see where the issue. It's 867.
Yeah.
So we'll make sure that's clear. Senate 86. Oh, that's just redundant, I think.
Typo.
Yeah, just a typo. Okay. I think.
Good edits.
Okay. I am a compulsive copy editor.
Might as well get it right.
Okay, so is there any other discussion? Anyone online?
Just a quick question. How often does the city council weigh in on, I know Councilor John had raised that earlier. How often do you weigh in on legislation? And when was the last time? And I guess maybe over the last couple of years, how often do you take up a certain bill and either show support or not, or against a bill? How often does that happen at the city council level that you do? Because just one other thing too is these bills, and I really appreciate Dr. Altman for coming and spending so much time. He spends a lot of time at the State House coming and testifying and hearings in the bills, and that's really the forum for everyone to come and learn about the bills and hear both sides of any argument on any bill. And so I just curious how often the city council takes up a bill like this bill or any other bill at this level to talk about supporting or not supporting a bill.
I see comments or questions from Councilor Mickley first and then Councilor Farrell.
Yeah, I'd say it's pretty rare. And honestly, I think it should stay that way. We have a lot of work to do in Newton, and we elect state representatives to do the work in the State House. But I just think Dr. Altman has made a convincing case for why this affects the city of Newton, which is why I personally supported it. And I think it's of interest to others as well.
And Councilor Farrell.
I would say amen to Councilor Mickley's comment. I mean, it isn't often. This is a very appropriate issue for us to comment on, and we hope that you will find our support useful, effective.
All right, any other comments or questions? So we have a motion to approve. All those in favor?
Aye.
Aye.
Are you voting?
I'm not on the committee.
Oh.
I'm joining, but I will be voting for this when it comes to the city council floor.
You're just
And I again want to thank Dr. Altman for all the time he's spent with us, and I can see this is sort of just the very beginning, right? Of a lot of work
towards the very end, actually.
Yeah, well,
Yeah, but beginning and end. So what does this vote mean that just happened?
So after this, it will go to the next full city council meeting with a positive recommendation. We were what, 5-0, I think we ended up. And then the full council will vote.
And what is effective, so this is a resolution that comes out of the city council, which would ultimately mean that this amended would end up in the hands of the folks here that doesn't fit about.
What is the timeline in terms of the city voting on this? 2 weeks.
It would be our, so
I don't think it'll hit the 27th, but it would be yeah.
I think it's the next meeting, is that right? We have our budget,
Yeah.
the budget presentation.
Yeah, but
and then we have a meeting after that.
I think there is.
Yeah. So it might be.
oh, it's not, it's 27th is the next meeting.
Is there a deadline?
Well, right, but that's Monday, so it could get there. I don't know how quickly it'll get turned around in clerk's office.
I guess it's since it was an approval and not a held item, I would have to develop a report for it to appear for a vote in the city council. So maybe you and I can talk about that tomorrow. And
Maybe we should turn the question around. Is there a hurry? Is there a reason for us to hurry?
Meaning the 27th versus the 5th?
Yeah,
There's no reason
Okay,
to.
I think let's aim for the first meeting in May, because I know the clerk's office is kind of swamped and understaffed.
So at the moment, the programs and services.
Councilor Representative Sanjay.
Hi, I just had a question on process. So after you guys vote on it by the full city council, will you deliver copies to each of the state reps? Who does it go to?
It will be going to state reps, the governor's office, I believe. I can double check on that.
So it's your law department will have that delivered to us, right?
It's going to be forwarded to Governor Maura Healey, Secretary of Health, Senator Cindy Friedman, Representative John Long, Senate President Karen Spilka, and Speaker Ron Mariano.
Can I put our state reps on there?
And us too, right?
Okay.
So we've got the co-chairs, the health committee.
Yes.
Well, at least to Chair Lon and to Rep Schwartz.
All the Newton State Reps, Amy, Greg, and myself.
Okay.
Right,
Oh, and
we'll make that amendment,
Thanks.
of course. And I think it'd probably come from the clerk's office, not necessarily the law department, just.
Okay.
At the moment, the Programs and Services Committee of Newton has endorsed,
Has approved the resolution.
has approved the resolution
Yeah.
As amended.
as amended and endorsement pending a vote by the city council.
Yes,
correct.
Okay,
thank you for coming.
Yes, thank you very much.
my pleasure. It turns out it's not a quick ride from Medford to Newton. Right, I guess the bird flies. It's not very far.
Are we-
I think,
It's one of those places that's not,
when you need a motion to adjourn, or do we not? Okay, I think, this is done and we adjourned. Thank you very much.
okay.
Thanks, everyone.
Thank you, everyone.
Thank you, everyone, for joining.